The first talk will cover dialysis-induced systemic stress, how to mitigate it to reduce mortality. So please welcome Professor Canaud.
So good morning. Thank you very much for your kind introduction, and thank you for the kind invitation to this, the first meeting of the Oman Society of Nephrology. And thank you for the president, and thank you for my colleague, Dr. Amer. So the talk today would be about dialysis-induced systemic stress. And when I will get the slide, that will be a little bit better. The idea is just to show that using the dialysis session, you are creating something which is new, which is a stress reproduced 3 times a week. And then this is part of, I would say, additional cardiovascular risk for the end-stage kidney disease patient. So the topic and the agenda is just summarized here. I will talk about what is a systemic stress in dialysis, what are the factors involved in this stress, what are the consequences, and how to mitigate the risk. The first aspect is, of course, we know from the definition. This is from Latin origin, and the concept of stress was developed by Hans Selye, who is an Austrian, I would say, physiologist, showing that at the end, when you are exposed to something which is unusual, the organism develops some reaction, and this is part of the stress of life. And this is exactly what's happening in dialysis. And we have a lot of factors called stressors induced by a dialysis. I will come to this point. The point in this is just a cartoon summarizing the topics. As you show, you can see dialysis creates a lot of stressors, and the stressors, depending on the reaction of the patient, have some adaptive mechanisms, functional, I would say, consequences. And this is what we call disease modifiers. It could be positive on one side if you have a stabilization of the hemodynamic, or could be negative if you induce, I would say, systemic ischemic. So that, depending on the reaction, you can have this type of, I would say, stress. Now, if you think about the dialysis in factors of stress, it's quite, I would say, strange to understand that the patient survived to the dialysis, because you have intermittent treatment, which is not physiologic at all. You have extracorporeal therapy, where you explore the blood and the protein. You have the kinetics of exchange, which expose the patient to tremendous change from osmotic, from electrolyte, from, I would say, inflammatory. And you have the poor overall efficiency altogether. So if you just think about the dialysis, this is strange that even after 60 years, the patient survived to the dialysis, I would say. Now, if you look inside the dialysis, what are the stressors? And this is a little bit more on the topic. One is, of course, the hemodynamic stress. And the hemodynamic stress starts with the ultrafiltration. We know that we have to remove fluid to control the pressure, to control the volume. And this is the first target. Second element is linked to the hemobiologic reaction. As soon as the blood is passing through the system, you have a tremendous interaction between the membrane, between the cells, between the protein, activating so many factors. And this is, at the end, I will show you in a minute, induced inflammation. And you get the biochemical stress, since if you recognize that the patient moves from, I would say, very high concentration to low concentration, from acidosis to alkalosis, and so on. And the last point is, of course, stress, which is linked to uremic milieu. Inflammation, oxidative stress, and all this substance. So we have to face, and the patient have to face all these elements. So the factors to understand, I put in 2 categories. One on the left is what we call hemodynamic stress. And hemodynamic stress is not only during the dialysis, but is also between the dialysis. On one side, you get, I would say, fluid overload, and the other one, you get fluid depletion. So it's a little bit like the tide up and tide down phenomenon that you have to understand. And on the other side, you have non-hemodynamic stress, which I mentioned about hemobiological reaction, biochemical reaction, biochemical changes, meaning that at the end, all these factors can contribute together to the dysfunction and organ damage. Few examples. this is hemodynamic stress. All study with a sensor put in the lung pressure to measure the lung pressure and to control the volume. As you can see on the slide, patients are either on the fluid overload or fluid depletion. They never get either in the isovolemic condition. That's part of the game. On the other side, on a dialysis, you are depleting the patient, and the patient is adapting based on the vascular resistance, based on a cardiac adaptation. But still, you create, I would say, on one side, the fluid expansion, meaning that you stress the cardiac system, and you stress all the vascular system, and the other side you can ischemic. And at the end, patients are facing such target organ damage, particularly on the heart, the brain, and the vasculature. Now, on the non-hemodynamic, and this is part of the element, you remember the coagulation contact phase, the complement activation, cytokine release, oxidative stress. This is part also of this, I would say, patient has to face. So now, just few elements on the bioincompatibility, and I was talking yesterday with some colleague about the water quality in Oman. You have to understand that it's not only linked to the membrane, but it's also linked to what you put in the dialysate and in the water. Because as soon as you activate the cells, as shown on the slide, you induce a lot of release from different mediators, reaction, and particularly you move to the inflammation, and the inflammation is certainly the enhancer of this morbidity and mortality in the patient, particularly on the cardiovascular. So now you understand that there is a global dialysis-induced systemic stress with multiple hits. So this is 3 times a week while the patient is exposed. Not moving. Could you move forward the slide? Doesn't work. No. Okay, it's okay now. This is what I mentioned, cyclically repetition of this phenomenon. So every time you activate, you release, and then the patient is exposed. So that means between the 2 sessions, the patient has just to get out of this biomarkers and biostressors that you have exposed. And this is 156 times a year. So it's a tremendous, I would say, challenge for the patient. Just put in perspective. Now, you start with the dialysis, you get the stress, and you have the crosstalk between the different organs. So you understand at the end, the outcome of the patient is not only just you do with your treatment session, you have to consider to mitigate this risk. And that has the point of the consequences. One is to consider the fluid overload, and this is why I put a question to the cardiologist. Main factors to address in dialysis patient or CKD patient is a fluid overload. We know that for many years, fluid overload is associated with high pressure, high blood pressure, but not necessarily. If you see this study from Zoccali, this is incident patient. If you look on the fluid overload measured by the bioimpedance, it's much higher as compared to the blood pressure for the cardiovascular risk. But now, if you look 1 year later, if you are not able to control the fluid overload, you see that the risk of mortality based on the fluid overload is moving from 30% to almost 60%. And this is independent from the pressure. So we have to realize that fluid overload has to be corrected. To correct the fluid overload, of course, the first step or the first approach is to make ultrafiltration. But again, ultrafiltration, if you are very aggressive, high-intensive ultrafiltration rate, so meaning ultrafiltration milliliter per hour per kilo, then you expose the patient to another risk, which is a fluid depletion and then ischemic condition. And this is nicely illustrated by the FLIGHT study. You should not move over 10 ml per hour per kilo. So if you get higher, you need to expand the treatment time to reduce this UFR. And this is a tremendous risk for the patient. I will show some element. Why is it dangerous for the patient? Because, of course, you put the patient in a hypovolemic condition, and depending on the hemodynamic, I will say, reaction or response for the patient, then you get hypotension. And we know from the study in our FLIGHT too, as soon as you get hypotension, less than 90 millimeter of mercury, so intradiabetic hypotension, 90 millimeter of mercury, then you expose the patient to higher risk of mortality from 40 to 60%, depending on the study. But this is a strong predictor of mortality. Now, again, this is a nice way of illustrating the cardiac risk or the hemodynamic status of the patient. If you make imaging of the cardiac system during the dialysis with MRI, which is a completely different story, you understand that on the study which was performed in UK, that whatever the technique, hemodialysis or hemodiafiltration, you get, I would say, ultrafiltration, you get hypovolemic condition, then you get reduce of the cardiac index, increase of heart rate and different elements. So you have some clinical consequences, but not only the clinical consequences. If you look on the cardiac system, you have what we call cardiac stunning. So there is a change in the strain, there is a change in a contraction or the systolic contraction of the system, which appear after, I would say, 1 hour or 2 hours. So that means the functionality of the left ventricular is completely changed. And this is certainly part of the element. But not only this functionality, but the perfusion. If you look on the perfusion, as soon as you get hypotension, then you get, I would say, peak stress, and you see the perfusion expressed by milliliter per gram per minute is reduced by almost 50%. So think about any hypotension is linked to hypoperfusion of the coronary system. Not only on the coronary system, but on the brain. And again, if you just look on this study, 1 year follow-up of MRI from the brain in a patient exposed to dialysis, either with hypothermic condition or isothermic condition, but you have white matters, I would say, change, and if you look inside precisely on the MRI, you see some, I would say, white matter abnormality, explaining partly why the patient gets cognitive dysfunction. If you ask a patient after the dialysis to make tests, you will be impressed by the loss of cognitive function. Not only on the brain, but on the kidney now. We get this type of information as soon as you get hypotension on the kidney. There is ischemic zone, you see on the peak stress, meaning that it's clear now, losing the kidney function is nothing to do with something which is magical. This is just resulting from the ischemic stress and the repetition over the time. So if you want to prevent ischemic stress and if you want to preserve the kidney function, you have to be very careful about the ischemic condition. Now the complement, and the complement also, even if you are using, I would say, polysulfone or biocompatible membrane, there is a sort of release of complement activation. It's not so high as compared to the ibuprofen, but still there is an increase of this complement. And if you look on the patient who get higher increase of the C3A or different element, and if you follow this patient for 2 or 3 years, you will find in this patient the higher response to complement, the higher risk of cardiovascular. So there is a link between this residual bioincompatibility and cardiovascular mortality. Also inflammation. I don't want to go into detail. I mentioned the inflammation, but this is a study was performed with a large data set of European centers, showing that at the end, if you look the protective effect of high BMI, which we observe in dialysis patients, now if you combine this high BMI with inflammation, then you completely reverse this paradoxical effect. And you have on the right part of the slide that high BMI with inflammation is not anymore protective. So the patient has high risk to death. So inflammation changed completely the profile of the patient. And the last point is hypoxemia. That was revealed recently by different study. If you monitor the hypoxia or hypoxemia during the dialysis, you will observe that about 10% of the dialysis patients get really hypoxemic during the dialysis, less than 80 or 85 millimeter of mercury. And now if you follow the life expectancy of this patient, right part of the slide, you see that hypoxemic patient will die 20-30% more as compared to the non-norm hypoxemic patient. So controlling hypoxemia is part of the game. So you understand there are many factors. Now, The point is how to mitigate the risk. Of course, the first element is to act on the hemodynamic stress, and maybe the second one is to act on non-hemodynamic stress. Hemodynamic stress, I just want to put in perspective. Treatment time, but I understand this morning from the docs that treatment could be increased. You need to increase the treatment time to reduce ultrafiltration rate. This is the only way to reduce such factors. Second point is to control the blood volume. Third is to control thermal balance during the dialysis session. Now is coming to the sodium management during the dialysis session, and the next would be artificial intelligence and predictive medicine. Just to show, if you increase the treatment time or the frequency, moving from, I would say, short to a little bit longer or more frequent, you see the ultrafiltration volume, or you can reduce the ultrafiltration volume, but more interestingly, you reduce the ultrafiltration rate, and then you reduce the cardiac stony, reducing the numbers of segments who are affected within the heart. So this is a nice way to understand why increasing time is beneficial for the cardiac system. For the cardiac system, and also if you take some cardiac biomarker, NT-proBNP or troponin, which are affecting this ischemic, reflecting ischemic attacks on the heart, you see that increasing time, nocturnal hemodialysis is a tremendous factor to protect the heart. Also, we can play with the ultrafiltration control on the machine, and that most of the machine gets this element. So if you set a machine to prevent this critical hypovolemic condition, I put 20%, usually it's less than 10%, then by doing that, you reduce the cardiac stress. And that was done in UK by Selby and McIntyre, showing that just a feedback control of the volume reduced significantly the left ventricular wall motion abnormality. So by controlling this hypovolemic condition, reducing to the threshold level, then you protect the cardiac stony. And this is part of the ultrafiltration, also showing that you can reduce the intradialytic hypotension. So you have to play with this element. And the third one is hypothermic. I know from here that hypothermia is a clear condition. But now if you do that in dialysis, you improve this vascular resistance. And just reducing or putting the patient on a negative thermal balance, you don't need to make very strong, but minus 0.5 centigrade, this is a way to reduce. And then by creating negative thermal balance, you increase the vascular resistance on the arterial side, on the venous side, you improve the vascular refilling capacity, and then you prevent or tend to prevent hypotension. That was done by Marjorie, I don't want to go into detail, a few years ago, showing that there is a nice way to improve the hemodynamic tolerance, reduce the numbers of hypotension. This is clear. But also now we know it's if you provide for 1 year, this is a way to protect the cardiac system. Look what they did in the UK again with the McIntyre group, showing that hypothermic dialysis has some beneficial effect on the left ventricular mass, left ventricular ejection fraction. So you protect the heart. This is one aspect. And again, unfortunately, the last study from Canada was my temp study was negative in showing some beneficial effect on the long term. But again, if you go inside the study, and we have a lot of concern about the methodological aspect of the study, I don't want to go into detail, but they were not able to measure the hypotension or the blood pressure within the patient. So that means they were not collected, and after the study, they make a sort of post-hoc analysis to randomize the centers and to collect a posteriori the blood pressure. So it's completely biased from the study, but still we have to accept the result. They did not find any improvement. Now, reducing the non-hemodynamic stress is also desirable. I will show some element. One is a diazide potassium. And I was impressed to see that you are dialyzing with a relatively low diazide potassium in a Gulf. You have to be very careful, because if you do that, and if you get less than 2 millimole per liter, and if you go down to 1 millimole per liter, you see the adjusted case mortality risk. This is if you have a tremendous change in the potassium concentration. Then you expose the patient to arrhythmia, and then this is high risk for the patient. So be careful with the management of the potassium. If you have to keep the patient on the safe side, 2.5, 3 millimoles, this is the minimum for the diazide potassium. And again, now if you make a modeling of the potassium and just reduce this decline of the potassium in the blood, this is a study was performed in France, showing that reducing this, I would say, potassium, you improve the hemodynamic tolerance, you reduce hypotension, and then you improve, at the end, the cardiac output of the patient. And the third or fourth element, I would talk later on the hemodiafetation. Hemodiafetation is a technique which has a beneficial effect, which is reducing the hypertension by 50%. That's a study was performed 12 years ago. And again, looking on the beneficial effect of the hemodiafetation, we know that exactly what I show on this cause-specific analysis, the reduction is linked to the cardiac element. Arrhythmia reduced, ischemic insult, and congestive heart failure are minimized with the hemodiafetation. So what is the final message from my side? I would say you understand that dialysis is quite stressful for the patient. And we put that in perspective. We have a sort of stress. We have a storm of cytokine, and then we get a sickness. So if we want to reduce this dialysis-related pathology, we need to move on different elements. Again, this is reality. We have a multiple component, as I mentioned. Hemodynamic component is very important. I just want to remember that fluid management is very important, but the fluid management is necessarily linked with the treatment time. So if you want to improve this, you have to increase treatment time or the frequency. Non-hemodynamic component, I insist on the biocompatibility on the membrane side, on the diazide purity, and then the last point is, of course, trying to personalize the treatment according to the response of the patient. Thank you very much for your kind attention.
Thank you.